Go.
Go.
All right. Hi, everyone. I actually gave an update on ARDS about 10 months ago now, just at the beginning of this calendar year. And so obviously a fair bit of the talk is similar to what I gave before. I tried to make sure that I added some recent research in some areas that I think are particularly important and relevant to the things that we do when we're managing patients with ARDS. So just in terms of disclosures, I do work as a consultant for the MHA and their hospital engagement network. I'm also a member of the critical care board, so I cannot give you a board review. I can never tell you a board review question. I have nothing to do with question writing. So you can't, nothing on here is on the boards because I'm teaching it to you. Just so you know that there are no exam questions in anything I'm going to do. And what I'm going to do today for you is go over sort of the definition of ARDS, speak specifically about the Berlin update and why there was an update to the way we diagnose ARDS, talk about physiology, and use physiology really to talk about all of the therapeutic options that we deal with in patients with ARDS. In that, give you a little bit more also about different sort of phenotypes of ARDS, talk about ventilator strategies, and then adjunctive therapies that are available in some ways we can streamline some of the things we do in terms of adjunctive therapies. So ARDS was first described probably most popularly in The Lancet in '67 by Drs. Petty and colleagues, including Dr. Levine from Michigan, where they described this pathophysiologic event in critically ill patients where they had severe dyspnea, tachypnea, cyanosis that was refractory to oxygen therapy. They noticed a loss of lung compliance and diffuse alveolar infiltration seen on chest X-ray. It's certainly a clinical scenario that we all recognize as ARDS. And this was then sort of formalized into a clinical definition by the American European Critical Care Consensus Conference definition, which was done in 1994. And they described patients as having ARDS if they had acute onset of symptoms, a compatible clinical history, bilateral pulmonary infiltrates, a wedge pressure less than 18, or absence of clinical evidence of left atrial hypertension, and then an impaired PA ratio with a PA ratio less than 300 being acute lung injury and less than 200 being ARDS. And so that was the definition up until the Berlin conference. And the reason for the Berlin conference was really to sort of go over some of the problems that exist in this definition. So the first is just a simple one. Although they said acute onset, they didn't define what acute onset meant. So everybody was allowed to sort of decide on their own what acute onset meant. You'll see that in the Berlin definition, they've tried to be a little more exact about what acute onset's meant to mean. The second part was that although they said bilateral pulmonary infiltrates, I don't think anybody can fix the problem with bilateral pulmonary infiltrates, but really the problem of that lies not in this chest X-ray, but this chest X-ray is from a paper by Gordon Rubenfeld, who's in Seattle, which is one of the ARDS network sites. And early on in the ARDS network, what he did was he got in a room and threw up a bunch of chest X-rays and asked the experts in the room, which were all of the critical care docs, is this chest X-ray compatible with ARDS? And so this one was not a tough one, and I think 95% of the docs looked at that and said, yep, that's compatible. But that X-ray, which every time I look at it looks normal to me, is 50% of the people in the room said that chest X-ray was compatible with ARDS. So a consistent chest X-ray is clearly in the eye of the beholder. So that's one problem. The other problem is that the definition says that you need to have a wedge pressure less than 18. Well, as many of you know, one of the studies that was done in ARDS with the ARDS network was looking at the question of, it's called the FACT trial. The FACT trial was a trial looking at running people with ARDS, wet versus dry. And the other part of the trial was whether the patients were randomized to being managed with a pulmonary capillary wedge pressure or a CVP. And so they had a whole group of patients with ARDS in whom we had our wedge pressure done. And you can see that 30% of the patients who clinically met the diagnosis for ARDS had a wedge pressure of greater than 18. So a third of the patients that we're going to say have ARDS have a wedge pressure greater than 18. And the majority of those had normal cardiac function. So it's not that all of these patients had heart failure. They really did have a clinical scenario that was consistent with ARDS, but there's no reason to say that you have to have a wedge pressure less than 18. You clearly can have a wedge pressure much higher than that and still have ARDS. And then finally, this PF ratio was never clear to people because, as you'll see, these are not mutually exclusive, right? So a patient with a PF ratio of 150 technically has both acute lung injury and ARDS. And some people thought that that meant they did have both. Some people thought acute lung injury was only 300 to 200, and then ARDS was anything below 200. Since that wasn't clear, the Berlin definition takes care of all of those things. The other issue with the PF ratio is that there was no requirement that it be on any particular PEEP. So this is just some animal studies, or some lab studies where they just took patients with ARDS and looked at their PF ratio at baseline, and as they exposed them to I think they did a PEEP of 20 in the study over about 6 hours, and you can see the PF ratio changes from 120 to 240 when the patients are just put on PEEP. So if you don't define a PEEP, you could technically have somebody with a PF ratio of less than 300 on a nasal cannula, and that would be consistent with the old definition. So the new definition tries to require at least some minimum PEEP if you're going to define a PF ratio. So that's what's wrong with all of that, and this is what we came up with. This is what the Berlin Consensus Conference sort of came up with. So in terms of timing, acute is now specifically defined as within a week of a known clinical insult or new or worsening respiratory symptoms. A week seems a little long, but a week is what we've agreed to. So at least it's not more than a week. I don't know that this is any better because, again, if you look at that normal X-ray and say it's consistent, you'll say there are bilateral opacities. But so bilateral opacities that are not fully explained by effusions, lobar lung collapse, or nodules. So at least they're at least allowing for certain things that can be consistent with ARDS and certain things that cannot be consistent. I think I'm not going to show you data. There's good data now that shows that about half of the patients who have even severe ARDS don't have diffuse alveolar damage on their open lung biopsies. So it'd be nice if all of this corresponded to diffuse alveolar damage, but even that doesn't work. And then sort of respiratory failure not fully explained by cardiac failure or fluid overload. So they just recognize that it's a clinical diagnosis. It has nothing to do with a wedge pressure. You think it's respiratory failure. You don't think it's because of heart failure. It's consistent with ARDS. And then finally, obviously, they just got rid of this whole acute lung injury thing and just talked about ARDS as being mild, moderate, or severe based on the PF ratio. So the PF ratio less than 100 is severe, PF ratio of 100 to 200 is moderate, and then 200 to 300 is mild. And they just showed, if you just look at the Berlin definition, it does make sense to have sort of this extra level of stratification in terms of looking at outcomes. So if you look at mortality, there's sort of there's obviously a higher mortality for ARDS than there is for ALI, but then when you divide that up, so obviously this mild ARDS is what used to be called ALI. When you put ARDS into a moderate and severe, you can see obviously mortality does go up, the worse of your PF ratio, and your vent-free days goes down, the worse is your PF ratio. So it makes sense clinically to differentiate ARDS into mild, moderate, and severe because that correlates well with outcomes. So physiology. So all of you recognize that there is sort of an inflammatory infiltrate that's part of what we're seeing when we have patients with ARDS. They have more of an inflammatory response, and with that inflammatory response, you get deposition of this fibrin membrane, the hyaline membrane. That's sort of the classic, sort of in pediatrics, what they call hyaline membrane disease, what we just call ARDS with diffuse alveolar damage, and white blood cells that are coming into the extracellular matrix. And although that is sort of the classic pathophysiology, what we find actually when we look at patients with ARDS, this is a study that just published 2014, Calfee and colleagues did, is they took all the patients that were in all of the ARDS network trials and just said, well, let me look at what's true about them. So all of them had everything you see along the bottom, they had measured for every patient. So IL-6, IL-8, their heart rate, their mini-vent, their ICAM-1, and they just sort of said, can we look at these patients, do they fit into, are they all in one phenotype or can they fit into two different phenotypes? And they used a methodology that actually they use to do things like when you have a group of crabs, if you're trying to decide if those crabs are from 2 species or 1 species, you can actually look at characteristics and say group is different than that group. That's what they wanted to look at. Is ARDS, is it all one thing? Are there 2 groups? Are there 3 groups? And what they found is when we talk about ARDS, we really should be talking about 2 different phenotypes. In old literature, we used to talk about pulmonary-centric ARDS and non-pulmonary-centric ARDS. There's a little bit of this here. So the phenotype 2, you can see, are the inflammatory phenotype. So they have higher levels of IL-6, higher levels of IL-8, higher levels of TNF, and they have higher vasopressor use. They're much more likely to be hypotensive, and they're more likely to be septic. So these are the patients that come in with a source of sepsis, typically outside the lung, who develop severe ARDS, the pancreatitis, the severe abdominal sepsis. Phenotype 2 are patients who are much more likely to have, so they have higher bicarbs, so they don't have the metabolic acidosis you see in phenotype 2. They have lower levels of protein C. They have higher levels of protein C, and they have higher blood pressure. So this is a less severe group of patients, but really when we start thinking about ARDS, almost nothing I'm going to show you other than for one other slide will talk about these phenotypes. But really, when we start thinking about ARDS, we probably are dealing with 2 different diseases that are going to respond differently to our therapies as we look at them going forward. The problem is obviously we don't have IL-6 levels and IL-8 levels and TNF levels for most of our patients. I think we understand these phenotypes. So somebody comes in with a large aspiration or with a trauma is a phenotype 1 patient. Patient who comes in with septic shock is much more of a phenotype 2 patient. And so when we think about that physiology, we're using the physiology in this mild, moderate, and severe to really talk about what we should be how we should be treating them. And obviously the first therapy, the therapy that is the mainstay of our therapy, is low tidal volume ventilation. And why do we think about low tidal volume ventilation? Again, if you think about the lung, and again, we should be thinking about the lung as sort of this idea of a baby lung. We have some parts of the lung that are normal, and we have some part of the lungs that have a lot of hyaline membranes, have a lot of exudate in the alveolar space. When that happens and we try to ventilate these patients, if we use normal tidal volumes, we're going to overventilate our normal lung. And what do you do when you overventilate a normal lung? And this is the classic example of that. These are obviously mice lungs. And this is a normal, healthy mouse lung. You take that normal, healthy mouse and you expose it to 5 minutes of CPAP of, I think, 40, and you start to see you get a little bit of this exudate, a little bit of lung injury. You expose that same lung to 40 minutes of that high pressure, and you have a lung that's just terribly sick, lots of what is now diffuse alveolar damage. So you've induced ARDS in a mouse by just presenting it with high pressure. So if you do that to the part of the lung that is now normal, that isn't affected with ARDS, worried that you get the same problem, and that led to ARMA. And ARMA was, as all of you know, is the trial of 6 mLs per kilo versus 12 mLs per kilo tidal volume with standardized sort of weaning. And what we saw, as you know, is that all the things that were important were better when you use lower tidal volume ventilation. And so mainstay of therapy for everybody, 6 mLs per kilo. As the fellows around with me know, I challenge you to explain to me why APRV doesn't fall into the same problem, because you don't get 6 ml per kilo tidal volumes when you're using APRV, but that's another talk. The interesting thing about this is that we've all used this because we know that when they did 6 mLs per kilo, they also said the plateau pressure needs to be less than 30. So we've all been taught tidal volume low, plateau pressure less than 30. What was then looked at, again, very recently by Amato and colleagues, when you look at what happens in the lungs, and they sort of took it, again, everybody that was in the ARDS trials, and all of the trials, low PEEPs, high PEEP trials, low tidal volume, high tidal volume, and tried to look at different characteristics of patients. So if you think about this, these are patients, 600 or so in each arm, who all are at the same PEEP, who are given a standard tidal volume and have a change in pressure. So it's not that these patients are on 12 mLs and these patients are on 8. They're all on roughly equivalent regressed equivalent tidal volumes. And they're just looking at what's the driving pressure. So in this patient, you can get the same tidal volume in with a driving pressure of 10. In this patient, you have a driving pressure of 40. So obviously, this patient has a higher plateau pressure than this, and you have a mortality that is correlated. So you can argue that the higher the plateau pressure, the higher the mortality, but really what they're showing is the higher the driving pressure, the higher the mortality. Because if you do the same thing by increasing your plateau pressure, not by changing your driving pressure, but just by changing your PEEP, you see no difference in mortality. So a plateau, every 40 plateau pressure is not the same. A plateau pressure of 40 when your PEEP is 5 is a very different animal than a plateau pressure of 40 when your PEEP's 20. So it's not about a pressure, it's about a driving pressure. It's not about an absolute pressure, it's about a driving pressure. And even on this, when you have the same plateau pressure, if the driver pressure is going down, if you're using higher PEEPs and able to put that lung in, as you have lower driving pressure, you actually have lower mortality. So it's not the number, it's not the plateau pressure, it's really about the driving pressure and about how stiff that lung is, what's the compliance of the lung, not what's the change in pressure. But obviously, to get all of that, we do it with typically low tidal volumes. And so the second part then is PEEP.
So we should adjust the tidal volume to less than 6 based on the difference in pressures, or based on the driving pressure, or let's say the plateau is like 40.
So I think the question is what the PEEP is.
The question relates on the PEEP.
So if the PEEP's 5 and the plateau's 40, we should go down on the tidal volume. If the PEEP's 20, then you might be fine with a plateau of 40. Okay. Because again, eventually you're going to go up on the. So it's about that driving pressure and what is the driving pressure. And I mean, there isn't a magic number into what's a safe driving pressure, but looking at these numbers, you can see that certainly the mortality is associated with these driving pressures that are in the range of 10, right? So 10 to 15 is certainly, I think, based on this, safe. But the problem is, obviously, the lung's not compliant. You can't make the driving. So then you really have to say how low, and that's our typical hypercapnic respiratory way of treating these patients, is we're going to hypoventilate them, let their CO2 rise, and tolerate some hypercapnia if we really are stuck in terms of compliance.
I have a dumb question. So if, for example, for that patient...
I know you too well, Renee. I think you can have a dumb question.
Plateau of 40 and a PEEP of 5. So if the driving pressure is, and I don't
35 in that case, right?
Right. So should we just increase that PEEP to meet that?
Yeah. So we'll talk about. So what you're asking is about recruitment.
Right.
So we'll talk about recruitment in a second.
Okay.
So yeah. So this is assuming steady state. You're asking, what if we're not at steady state? Can we push down our driving pressure by optimizing our PEEP, which is a perfect segue into what I'm going to talk next, which is PEEP. So PEEP has been, the Berlin guidelines sort of say that the way we should drive therapy is for patients with sort of mild to moderate ARDS, we use sort of low PEEP, and in patients who have more severe ARDS, which clearly is somebody who's got a plateau pressure of 40, we should be using higher PEEP. Why do we say that? So obviously when we're talking about ARDS, we have this thing, we want to try to increase the PEEP so that the abnormal lung is working as normally as we can, at least in terms of driving out, trying to improve FRC, driving out any intra-alveolar water, and trying to improve our ability to oxygenate. But probably more importantly, as you all know, what we're trying to avoid, the first slide I showed you was how we can harm the lung with the ventilator. Everything we're doing with ARDS is how can we prevent lung injury with the ventilator. And so we know that there are a variety of different ways of causing ventilator-induced lung injury. One of them is barotrauma, so that's really trying to avoid the high pressures and trying to avoid any over-distension of the lung. But there is also this idea of atelectotrauma, which is basically this idea that an alveolus, when it opens and closes, that there are shearing forces that those alveolar macrophages are exposed to, and those shearing forces cause cytokine release and cause increased inflammation, and so you want to try to keep the alveoli open. You don't want them opening and closing, and that is why we try to avoid atelectotrauma. And so when you think about this curve that should be ingrained in your heads, of sort of the hysteresis you get in somebody with ARDS, right? You're taking a lung, you're starting here. I always think of it as a balloon that you just bought. You're trying to blow it up, and it's just not going. You finally get the point where it opens, and you get past that lower inflection point, and then it's opened, and you're trying to ventilate in here and trying to avoid to the point where you overdistend, where that balloon is, you just can't put any more air in it. So we're trying to make sure we get above the lower inflection point so we can avoid atelecta trauma, and then we're trying to keep below the upper inflection point so we avoid volume trauma. So we're staying in that range, and there certainly is the thought that if the problem is you're having, if in that patient who's got a PEEP of 5 and a plateau pressure of 40, if we're not getting this piece fixed, we may not have the ability. What we're ventilating are just small segments. If we can ventilate more, we can improve our mechanics. And so certainly when we look at ARDS therapies in terms of high PEEP, so using higher PEEPs than lower PEEPs, this is a meta-analysis of 3 studies, which I'll go over in a second. All 3 of them did not have an outcome in terms of mortality, but when you look at mortality, and again, you look at patients, so the graph says with ARDS and without ARDS, and that's just because the paper was written before the Berlin definition. So with ARDS is mild to moderate, moderate to severe ARDS, using the Berlin definition. Without ARDS is just acute lung injury, which now we would call mild ARDS. So in mild ARDS, there's no mortality benefit. In moderate to severe ARDS, there is a mortality benefit for high PEEP, and that's in terms of days, time to unassisted breathing or ventilator-free days, it's beneficial for both groups of patients, or for all of our ARDS patients. The problem is, I can tell you it should be high PEEP. I can't tell you how to do high PEEP. So if we're going to do low PEEP, this is what hopefully everybody is using when we use low PEEP. If you have somebody with mild ARDS and you need to titrate your PEEP and your FiO2, you're using this table. Not because this table's right, but because it's something we can at least all look to, so we all know what we're doing. But then if you want to do high PEEP, you can use high PEEP that we used in the alveoli trial, so that's the ARDS network trial. So you can see how quickly you get up to very high PEEPs, right? You can't get above 50% FiO2 if you're not on at least a PEEP of 20, and for many patients you're going to be around 24. So you're on very high PEEPs very quickly to try to improve lung recruitment and try to prevent atelecta trauma. This is the lung open ventilation study, which was another trial. They used slightly different PEEPs. They used two different algorithms, one early, one late. You can see they're close, but you could use either one. They're not that different from alveoli, but they're a little bit different. The Express trial, which was the 3rd randomized trial, said we want to use as high a PEEP as possible so that we don't get overdistension. So they were saying, like, we want to look for overdistension. If we think we're hitting that upper inflection point, we'll come down on the PEEP. But until we hit that upper inflection point, we're not going to come down on the PEEP. How did they know they hit the upper inflection point? They used something like this, which is the stress index. So all of you should be familiar with this, right? So this, again, in a constant flow, I can't use this stupid thing. In a constant flow status with the vent, which all of you should remember is not the way our vents work, right? They're all in autoflow. They all have decelerating ramps, so you have to turn autoflow off. But if you turn autoflow off and you look at pressure over time, you're going to see, in theory, you're going to see one of 3 patterns. You're going to see an underinflated lung, right? So over time, the first half of the time you're pushing the air in, the pressure goes up relatively quickly relative to time, and then it goes down, it goes up slower. So again, that's the hardest part about this, is because in your head, at least for me, I'm thinking pressure volume curve. And the pressure volume curve is not what this is. This is a pressure time curve. So get the pressure volume curve out of your head and just think about pressure over time. If pressure goes up quickly early and slowly late, that's a lung that's not open. If it goes up low early but high late, that's a lung that's overdistended. If it goes up in a straight line, perfect. That's what you want. So it's really, it drives, every time I'm at the bedside I have to stop because I always want to think about the pressure volume curve, which is not this. But this is underdistended, this is overdistended.
I mean, if you just look at it a simpler way, That one looks like a sad face, so you need
What?
a sad smiley face. This one,
So this is a sad. So a low PEEP is sad and high PEEP is happy.
yeah, smiling. Another one is more confused.
When are you taking boards?
Last week.
That was pulmonary though. Whatever works for you, Mohammed. If that works for you, that's fine. The problem with it, to be honest, is this is what I see at the bedside, and this is what so this one looks like a happy face. This one looks like it's straight. So is the problem, are we over-distended or are we okay? And that's the real world problem with this, is that when you try to do it at the bedside, it's really hard. And it's, if you think about it, okay, you do it and you think, okay, it's clear the patient's under-distended. So I'm going to go up on the PEEP. Are you going to do it again? Are you going to keep switching? How often? And you can just remember, this. I took this off our vents, and obviously you can see the flow is flat. So you're in the right scenario. But it's really hard to do. And so given all of that, Dr. Gattinoni's group did a really interesting study. So they took a bunch of patients with ARDS, and they looked at how they could change the PEEP. They would try to find the ideal PEEP for every patient, and they would try to do that based on the protocol for the lung open ventilation study, which is totally a algorithm, right? If the FiO2 is X, I'm going up on the PEEP until I can get an FiO2 that's stable. So I'm just doing it based on hypoxemia. Express, which is basically using the stress index I just showed you, which I mean, it's not different from the stress index, it's just like the stress index. And then they exclusively use the stress index. And then they use esophageal pressure monitoring. So you guys don't see esophageal pressure monitoring. The algorithm for esophageal pressure monitoring, the idea is you take a patient, you let them exhale, you measure the intrathoracic pressure when the patient has got an expiratory hold. You measure that pressure, and whatever the pressure is in the thorax at end expiration, you make sure the PEEP is higher than that. So basically you're saying, okay, that's 0. So if you put in an esophageal monitor, you have somebody on a vent and you let them exhale and their intrathoracic pressure is 25, you set the PEEP to 30. Because the PEEP's got to be higher than whatever you think because you want a driving pressure. You want some transpulmonary pressure, so you have to get a pressure that's higher than what is your end expiratory pressure. We don't do that, you don't see that, but this isn't going to convince you to do it, believe me. And so then what these researchers did is then they said, well, if these protocols make sense, you should be using higher PEEPs in more severe ARDS. So they looked at, again, sort of blinded to whether the patient had, not really blinded in this case because they're using oxygenation, but blinded to the severity of the ARDS, what was the average PEEP they thought was ideal using these different protocols. And what you'll see is there's no correlation between severity of disease and, other than for the LOVS or for what we've always used for alveoli, which is just a PEEP FiO2 table. So you do it based on hypoxemia. Interestingly, they then looked at the quartile of lung recruitability. So they took these patients, sent them down to a CT scanner, did a CT scan at 5 centimeters of water, did another CT scan at 40 centimeters of water, and looked at how much more lung was recruited at 40 centimeters than at 5. So they could decide how recruitable the patient was, and they just put them in quartiles. The numbers don't mean anything at the bottom. Just think of it, this is the least recruitable, and that's the most recruitable patient. You can see for, again, this open lung ventilation, there's a nice correlation between the PEEP they ended up with and the degree of recruitability. The more recruitable patients had higher PEEPs. It was exactly counterintuitive. It's basically scatter for everything else. So all of the physiology we'd love to bring to the bedside is nice, but the reality is, use a PEEP FiO2 table, you're probably going to get as reasonable an outcome in terms of matching higher PEEPs with patients who are recruitable, although it's a lot more fun to look at a stress index.
So when you go back to like the alveoli study, are you saying that that data is sort of negative data in the setting that they grouped all of the severity together, that they didn't separate them out by lower and higher severity?
No, I think my sense of all the 3 of those studies is that they all were underpowered for the small survival benefit that they ultimately showed in groupings. I think, and my next slide is another reason why that might be wrong, but in terms of those studies, I think they all showed a benefit, but the benefits in all three of them were, a couple of vent days, not enough for anyone to say, yep, absolutely, I want to do this. When you put them together, I think they show a real signal that higher PEEP is associated with better outcome. It's clearly in patients with higher, but even the subgroups in those little studies, you couldn't show it for just ARDS patients, but it was there. But again, the other thing I talked to you about was we're now really should be talking about, in some ways, two diseases, so phenotype 1 and phenotype 2 in terms of ARDS. So when you look at phenotype 1, you can see that, again, this is mortality, but those researchers, when they figured out, okay, here's a whole bunch of patients who are phenotype 1, here's a whole bunch of patients of phenotype 2, some of the phenotype 1 patients were randomized to low PEEP in some of these studies, and some of them were randomized to high PEEP. When you look at that, you see that there's a nice PEEP, there's nice survival advantage for phenotype 1 patients. They are very PEEP responsive, whereas these very sick, stiff, septic shock patients who are all more likely to die, the high PEEP was less, sort of counterintuitively, was less useful. So there probably is a group where the higher PEEP makes much more of a difference than another, and we just don't know how this all fits in to all of the other studies, because this phenotyping, which seems to be real, is not something that we do routinely, so we don't really know where our patients fit in a lot of these studies. So after we talk about PEEP, then the question is, can we use non-invasive ventilation for patients with mild ARDS? So that's the other therapeutic trial. And there's no randomized control trial of non-invasive ventilation. The studies basically do what I'll show you for one of them, which is takes a whole bunch of patients and says, yeah, let's put them all on non-invasive ventilation. Let's see what happens. Some patients are going to get intubated. Some patients are not going to get intubated. Can we think that maybe there's a benefit to non-invasive, thinking if somebody doesn't get intubated, they're probably going to be better off than if they got intubated. And what you can see, and this is one such study, they sort of said, okay, here are a bunch of patients over the last few years that we put on non-invasive ventilation. You can see, and then they compared it to a group of patients who had COPD, pulmonary edema, things that we normally use non-invasive ventilation for. They could show that in patients with mild ARDS, the percentage of patients who got intubated was no different than the percentage of patients who got intubated who didn't have ARDS, whereas once you get to moderate or severe, all these patients are going to end up intubated anyways, or at least a high percentage are going to end up intubated anyways. Don't delay things. And that brings me to this.
So
Go.
They used it like prophylactically? Or between
quotations? They used it, if I remember it correctly, they used it the way we use, the way the studies use, not the way we use it, the way studies use non-invasive ventilation for things like pulmonary edema. Once you're on a FiO2 of 50%, at that point you get randomized to stay on your 50% oxygen or get switched to non-invasive ventilation. So, right, I mean, that sort of leads into my point, which is the concern I always have about non-invasive ventilation, and I would have it in ARDS probably more than anywhere else, is that we tend to use non-invasive ventilation when we think somebody needs to be intubated, which is just way too late. Other than for patients with COPD or pulmonary edema, we tend to use it as, okay, let's see if we can skate by. And that's where we get into trouble. And I get that mainly this is my favorite why not to use non-invasive ventilation study, sort of. This was for post-extubation respiratory failure. So they took a group of patients who were then randomized to either get non-invasive ventilation or standard medical therapy. And so standard medical therapy was oxygen. Non-invasive ventilation was what it is. You can see that the number of patients who got reintubated in the two groups is almost exactly the same. Some of them actually got crossed over to here, and they ended up getting intubated as well. But the mortality here is much higher than the mortality here. And I've always interpreted this to mean if you are putting somebody on non-invasive ventilation, you tend to delay your intubation. And that my thinking is the delay in intubation is what leads to the higher mortality in a study like this. And that if it probably would be reasonable if we had a protocol to say, okay, you have somebody who meets criteria for mild ARDS. Otherwise, I would just be putting them on non-invasive ventilation. I'd be putting them on oxygen. I'll put them on non-invasive ventilation. That makes sense until, and I don't have this study, I forgot to put it in. until you see the recent study, which actually says those patients do better on high-flow nasal cannula, which is what I would now use. But before that study, I think you could argue for that. I think now, I don't know that non-invasive ventilation really has a role in ARDS. I think if you're going to use, if you have a patient who's got ARDS who needs oxygen, they really should be on high-flow nasal cannula. If they fail high-flow nasal cannula, they need intubation. So neuromuscular blockade, and so the idea of neuromuscular blockade, which is an interesting one, is just the idea that there are things that are going on between the patient and the ventilator that probably early in their course are causing worsening of ventilator-induced lung injury. So obviously you have this patient-ventilator dysynchrony here, so the patient's breathing when the ventilator is not breathing in, when the ventilator is breathing out, et cetera. And with that dysynchrony, you're getting an alveolus that's over-distended when they're breathing in, when the ventilator is providing a breath. So we all know patients we set to 6 mLs per kilo. When we look on the ventilator, they're getting 8 or 9 mLs per kilo because they're assisting. Or they're breathing out when the ventilator is trying to breathe in. So now you have increased pressure in the lung, which is going to lead to increased alveolar permeability. Or you have active expiration to the point where you're calling these lungs to close, you're calling these alveoli to close, and you're developing atelectotrauma. All of that leading to more biotrauma and increased cytokine release. And so the idea is if you paralyze them early, you're getting rid of all of those issues. And so you have less atelectotrauma, less barotrauma, less biotrauma, and that is basically what is seen when you look at paralysis for early moderate to severe ARDS. So this is, as most of you know, this was paralysis for 48 hours early in the course of ARDS, not for recalcitrant hypoxemia, which we sometimes use it for late, but just to prevent ventilator-induced lung injury. When you do that, you see a decrease in mortality, increase in ventilator-free days. And again, I think this is really the key, is sort of the barotrauma that you're getting with placebo is much higher than you're getting with paralysis. And this number of about 10% is what we've seen in other studies. So that's not artifactual. That seems to be real. And in case you're interested in knowing whether that's real, we are going to be starting probably in a month or two to do the ROSE trial. The ROSE trial is, this is the PEDAL network, is the new ARDS network. It's now called Prevention and Early Treatment of Acute Lung Injury. It still has acute lung injury in it, either though that's not a term we use anymore. And ROSE is they always come with these stupid acronyms, reevaluation of systemic early neuromuscular blockade. So basically patients with a PF ratio of less than 50 on a PEEP of 8 are then going to be candidates for this trial, and we'll be looking in your units, our units, for patients, and we're working in collaboration with Dr. Rivers, so it would be in the SICU as well. And we're trying to get patients even early, at least for our next trial, which will be a vitamin D trial, certainly in the ED for patients who are at risk for acute lung injury. So this will be... What's that? Early goal-directed ROSE. There you go.
Definition of early?
And this is obviously not early, right? Because this is moderate ARDS. So the early part of the PEDAL network is going to be the next trial. So the next trial is going to be a vitamin D trial. So
no, the early, I mean, within the first week.
Once you see early, I think it's the 48 hours is what I remember, but it might be 72. I think it's 72. In terms of enrolling somebody for paralysis, yeah, I think it's 72. 72 hours from when they meet those criteria. So that'll be coming, so look for that. Help us find patients, help us get patients enrolled. So we'll try to answer that question of whether that first study for neuromuscular blockade is real. So the next issue is prone positioning, which is kind of interesting, and I'll tell you how we're dealing with that in ROSE because it's going to come up. So this is early work by Dr. Gattinoni that sort of started this issue around prone positioning, that he showed when you took patients and put them on their stomachs, there was an increase in FiO2 that sort of got worse after they stopped. They put them back on their back. The idea being simply, if you look at sort of the top two, this is end expiration and inspiration for a patient who's supine, and you flip that patient prone, and you can just eye it and say that there's a lot more sort of recruitable lung when you flip somebody prone, and that recruitability is what is the idea of why prone positioning should work. the problem with it has been up until recently, it never worked until the Procedure trial. This was a multi-center trial in France, 500 patients, 80% on vasopressors, 85% on neuromuscular blockers. The one problem I have with the study is the neuromuscular blockers, which I'll talk about in a second, but this is the outcome. So the outcome was amazingly good for the prone patients. They had much lower mortality than the patients who were supine. And this is sort of this interesting cumulative risk ratio. It's sort of, as you can see from the early studies by Gatnoni down to Guerin, these are all the individual sort of point estimates of the value of the study, but you can see that over time we've gone to favoring supine to favoring prone, just every study being a little bit better in terms of improving patients prone. One of the things that's changed is the amount of time patients are sending prone. So Dr. Gatnoni, I think, was doing 6 hours. Dr. Guerin did 16 hours. So patients are spending much more time prone as we go on. Although I think early paralysis makes lots of sense, I think prolonged paralysis is probably a bad idea. And so I do worry in this trial that if they paralyzed everybody, you sort of have I think you might have to paralyze the patients who are prone, but if you don't have to paralyze supine patients, you might have an advantage there that wasn't caught in this trial. In the Rose trial, there's no preconceived ideas of whether patients can be prone or not be prone. We get to decide that on our own. It would not be a protocol violation if you wanted to prone somebody. There's lots of reasons we don't do that well, but you could do it in the trial. I'll skip that. The other thing that I think sort of gets to the idea of paralysis is the high-frequency oscillator. So again, if you think about what we've been talking about, what would make the most sense to ventilate somebody with ARDS is to put them here and leave them there, right? Open up the lung, keep it open, don't let any other electrotrauma occur, don't let no way you go above the upper inflection point. Oscillation sounds perfect. You've recruited the lung, you keep it open, and then you just do this funny vibratory thing, and you ventilate, and you're fine. And so this should work great, and it doesn't. And so this is the Oscillate trial, run out of the Canadian Clinical Trial Group with Neil Ferguson, showing that when you randomize people with moderate to severe ARDS to oscillation, they actually do worse than the control group. And then there was another trial, the Oscar trial, at the same time that really showed no benefit. So the no benefit was better than the worse, but clearly there's no reason to use this. And so if you ask, if the physiology fits so well, here, let me go back to the physiology, why doesn't this work? Because it should work perfectly. And so I think there's two possibilities. One is that patients who need to be oscillated need to be paralyzed, and it's the downside of being paralyzed for a prolonged period of time that leads to the other bad outcomes. Or oscillating the lung causes a cytokine release or does something else to the lung that we don't understand, and that's what causes these poorer outcomes. But clearly oscillation doesn't work. And so the final thing is ECMO, which is obviously something we've been thinking about more. Got my first transfer for an ECMO case yesterday. And so there's 3 trials of ECMO. They're not again, these are not going to convince you that you should do ECMO, but this is the literature we have. So this is the early trial from Dr. Morris and his group from Utah, and they looked at sort of whatever they normally did for patients with ARDS and compared it to extracorporeal CO2 removal and showed that there was really no difference in outcomes and mortality in their patients. My favorite part of this trial is they actually managed the patients who were in standard therapy. So this survival of 40% was much higher than what had previously been published for ARDS before Dr. Morris and his group published this in 1994. And part of the thought of the reason for that was for his patients in the control group, every ventilator change was decided upon by a computer. They actually had a computer that had an algorithm that said, if give me a gas, give me settings, I'll make a change. And the nice thing about that is that you can write that algorithm. It's not terribly hard, and it gets done 24 hours a day, 7 days a week. Doesn't matter if it's who the intern is on call, what the nurse is doing. These changes are happening automatically all day. And with that, they were able actually to show much better outcomes for patients with ARDS. Then this was a trial where it took a variety of ECMO centers. This was the second attempt to show the benefit of ECMO. This actually included the University of Michigan, where Dr. Bartlett was doing a lot of his ECMO work. And again, randomized patients to mechanical ventilation in these centers versus mechanical ventilation plus ECMO, and we're not able to show any difference. The concern was, well, these were all great centers, and this might not be, because again, this might not be indicative of what would happen at other centers. So then finally, this was the last trial. This is the Caesar trial. In this trial, they sort of said, okay, we want to take regular patients wherever they are in the community. This was actually a European trial. And then if they need ECMO, we'll move them to an ECMO center. If they don't need ECMO, we'll leave them where they are. So they took 180 patients and they randomized them. So 90 were assigned to receive ECMO and 90 were assigned to receive conventional therapy. These 90 stayed where they were and got conventional therapy, and ultimately 44 died by 6 months. You'll see 33 died here, so it looks a lot better. What's interesting, though, is that of the 90 that were assigned to ECMO, 22 of them never actually got ECMO. So 16 improved with conventional management, 3 died on the way, 3 died within 48 hours before transfer, 2 died during transfer, and 1 had a contraindication to heparin. So when you look at this study and you say, gee, ECMO did better, that includes the patients who never got ECMO. If you look at this trial and only include patients who got ECMO, there's no survival advantage to ECMO versus conventional therapy. So it's a really difficult, if you want to look on the sunny side, if you want to be an ECMO center, you say, well, send your patients to us. Whether we do ECMO or not, they'll end up better off. That's one way to look at it. And so non-ventilator things. So there's 2 things that are really probably key questions when we're dealing with patients with ARDS. One is fluids and the other is steroids. And so again, obviously, when we're talking about fluid therapy with ARDS, again, we're talking about lungs that are full of extravascular lung water. And the idea would be if you dry these patients out, they're much more likely to have improved outcomes because of the increased permeability and the increased hydrostatic pressure that exists for patients with acute lung injury. And so the New England Journal trial, the FACT trial that was done in 2006, again, one arm was SWAN versus no SWAN, or CVP. The other arm was conservative fluid management, which was to dry the patient out as much as possible with the idea of decreasing edema, versus a liberal fluid management, which was the thought was, well, if we're more liberal, we'll increase cardiac output since these patients have sepsis and they need better cardiac output. And so when you look at that study, what they clearly showed that the conservative strategy, whether you're looking at mortality at the top, but probably more importantly in terms of gumming off the vent, which is what all of us have seen when we've rounded in the unit. You get somebody dry over about a week and they come off the vent. And that's certainly what they saw, is huge improvements in being able to be extubated from the ventilator once you were randomized to this conservative strategy. The problem with the conservative strategy has been this, and I used to walk through all of this for you, but I'm not going to do that because we have this now. So ever since the initial FACT trial, there have been 2 or 3 or 4 other ARDS trials where they said, okay, we've shown conservative therapy is better. We want to do it in all these other trials, but that algorithm was a pain in the neck. So let's just do this. So this is called FACT Lite, and this is what FACT Lite is. So it's much easier because there's 6 boxes instead of 15 boxes. So, and it does give you a lot of nice sort of things I always thought about. So first of all, you have to have a mean arterial pressure greater than 60, and you have to be off pressors for 12 hours. So we're always on rounds. I always feel like we're like, okay, they came off pressors yesterday. Can we start diuresis today? So if you're going to follow this algorithm for your ARDS patients, as long as it's been 12 hours, you can start diuresis. As long as they're CVP, and then you need a CVP. Or you need your best guess of what the CVP would be, but the CVP is what's recommended, not the wedge pressure for sure. So if the CVP is greater than 8, if they have low urine output, you give them Lasix and you check in an hour to see what their urine output is. If the urine output's still low, you keep giving them Lasix. If their urine output's reasonable, 0.5 mLs per kilo, you give them Lasix and you come back in 4 hours. which means you come back in 4 hours and you give them Lasix again. And you come back in 4 hours and you give them Lasix again. And you keep doing that until the CVP is down here. So if the CVP is 4 to 8, if they don't have good urine output, you're given fluid. If they have good urine output, you're given Lasix. When the CVP is less than 4 is the only point you get to stop giving them Lasix. So it's Lasix every 4 hours until you get a CVP less than 4. And then there's all this good stuff down here about what do you do for shock, what do you do about the creatinine, which has always been my question, because it's never that they got hypotensive, it's that their bicarb is 35, their sodium's 120, their creatinine's starting to go up, and am I still going to give them Lasix? So they give you sort of a creatinine greater than 3, or oliguria with a creatinine less than 3 are good reasons to stop sort of giving diuretic therapy. But they at least there's some guidelines on here, which they probably were in the algorithm that supported this, but I could never find them. Yes, Manny.
I see fat cells and albumin in that.
Shh.
Go to the next page, you see. Right,
Yeah.
A shot said give vacuum cracked red cells with 25 grams.
Yeah, well, they didn't get everything right, Manny. That's okay. So steroids is the last thing I want to talk about. I know I'm about out of time. So obviously we have an inflammatory milieu, so it makes sense to at least think about steroids. And these are the studies that have looked at. So you can see the meta-analysis is not positive. So from a meta-analysis point of view, you certainly could always argue, I'm not going to give anybody with ARDS steroids, and you wouldn't be wrong. I'm interested in these two studies. One, because the Maduri study is probably the first study and the one that was the most positive, almost too positive, and the Steinberg is the ARDS network trial, which is the biggest study that had been done, multi-center in the U.S., and non-studies about the same size. So this is the Maduri study, and again, he only had 24 patients, 16 got solumedrol, all after day 7, 8 received placebo, and you can see, I mean, this is crazy. I mean, steroids do not improve your survival by a factor of 2. There's no way that's true. I don't know what's in the water in Italy, but clearly steroids help it. But this is the ARDS trial. So the ARDS trial, ultimately, again, if you're looking at survival, which is the pink and the black up top, there's no difference. The interest has been this, that there does seem to be this earlier extubation for patients who got steroids in the ARDS network. And so people have talked about, is it the way they use steroids? Is there something they didn't do late that they should have? I don't know, but there definitely is some earlier time off the ventilator with steroids. No difference in mortality, but clear difference in vent-free days. So that's what I use to use steroids when I'm going to use them, and I must admit I use them for patients who have prolonged ARDS, and I use it specifically between days 7 and 14. So the other thing they showed was that if you wait till 14 days of later, the mortality with steroids was huge. The mortality with placebo wasn't so big. It doesn't make all that much sense. But maybe the patients in whom you decide to use steroids late, that they're going to do fine if you just leave them alone. But clearly early on, if you're using it between the 1 week and 2 week, there does seem to be some advantage in terms of mortality for steroids. And that, again, is the meta-analysis. And so that's all I went through.